Hello everyone, welcome to the Differential podcast. I'm Dr. Assem Al Refaei, and today we are dissecting the bleeding patient, a high-yield must-know topic for Step 2C care or any other clinical exam. We will review some physiology, primary, secondary hemostasis, and multiple platelet and coagulation disorders, along with other not classically deemed as platelet and coagulation disorders, but ones that could present with bleeding. And we will mention tricks that show up on exams along the way. So let's get started. First, with the physiology of hemostasis, it's obviously having two parts, the primary and the secondary. Whenever someone have an injury, let's say a skin incision, the first thing that will happen is primary hemostasis, where the goal is to create a platelet plug that will stop the bleeding. The first step, since I had an injury and there is a blood vessel that was injured, there will be exposure to the subendothelial tissue in that vessel. So the vessel has endothelium, which is a single layer of squamous cells, and that was injured, so we have access to the beneath layer, which is the subendothelial collagen specifically. Von Willebrand factor is going to be important here as it will bind to the subendothelial collagen, and then you will have platelets adhering to the von Willebrand factor using their GB1P receptor. And this is going to be the temporary plug that will get formed here. As you can see, from this moment on till the end, any problem could rise and result in a bleeding patient. First of all, having little platelets, which will not make a sufficient plug to block the bleeding. Maybe having a problem with the adhesion of the platelets to von Willebrand factor, which could be seen in Bernard-Soulier syndrome. Or maybe in platelet aggregation. So let's say one platelet adhered. We want platelets that are adhering to aggregate, and here you are going to have a problem in Glanzmann thrombasthenia, which is another disorder due to a defect in GB2P3A receptor. So as you can see, there is different ways primary hemostasis could be defective, leading to bleeding disorders. And usually with the primary hemostasis, the abnormal labs are going to be the platelet count or function and the bleeding time. In all of the disorders involving primary hemostasis, which means the platelets, there is no coagulation factors involved here. In all of these disorders, the bleeding time is going to be prolonged. What differentiates quantitative from qualitative, so quantitative is anything with a thrombocytopenia. Obviously what differentiates is the thrombocytopenia, platelet count would be low. While in qualitative disorders, platelet count would be normal. However, these normal amounts of platelets are not that much functional. And that's what happens in Bernard-Soulier and in Glanzmann thrombasthenia. The shared feature between quantitative and qualitative, again, is the prolonged bleeding time, and this differentiates them from diseases of secondary hemostasis, which involve the coagulation cascade. Now, symptom-wise, people with primary hemostasis present with mucocutaneous bleeding, like petechia, gum bleeding, heavy menses, and these point again to a primary hemostasis defect, even hematuria, bleeding from mucosal or skin sites. However, in secondary hemostasis, the bleeding will be deep, meaning hemarthrosis, involving joints or within muscles, so muscle hematomas as well. Secondary hemostasis, the goal of it is to strengthen the plug with fibrin. And to get to fibrin, we will have to go through a coagulation cascade. I'm not going to delve deep into it for the sake of time, and because we are oriented toward differentials, I will just mention the clinically relevant points. We have two pathways that are involved here, the intrinsic and the extrinsic. Intrinsic pathway, the laboratory value that follows it is the partial thromboplastin time, so PTT. While with the extrinsic pathway, it's the prothrombin time, so PT. The intrinsic pathway is defective in hemophilia A, P, and von Willebrand disease. So in these disorders, we expect partial thromboplastin time, PTT, to move up. It's going to be elevated. While prothrombin time is going to be elevated in individuals with vitamin K deficiency and people who are taking warfarin. All right? So, and just a point before moving to diseases and tricks and differentials and more details, vitamin K deficiency and warfarin eventually result in elevation of both PT and PTT. However, at the beginning, the first to be elevated is going to be PT, so prothrombin time. And that's why we use it in monitoring warfarin. And INR is a value that is given from prothrombin time. It's calculated using prothrombin time. Okay. However, PTT will be elevated in both vitamin K deficiency and warfarin, but not so early. All right. While in hemophilias and von Willebrand disease, even if someone has it for 10 years, always only partial thromboplastin time will be elevated. So now, I want to touch on the platelet disorders. So the ones concerned with the primary hemostasis. Immune thrombocytopenic purpura is the most famous one that you are going to see. And from the name, it says thrombocytopenia and purpura. So you will expect some skin bleeding in these individuals. And since it's a platelet disorder, you have the mucocutaneous. So they could bleed from their mouth, they could have nosebleeds, it could be heavy menstruation, all of these conditions. And this is not a genetic condition, it's an acquired one. And usually it happens after viral infection in children and also in adults. So usually it's preceded by an infection and then someone's developed immune thrombocytopenic purpura. It could also happen in individuals with autoimmune diseases. Like people with SLE, they are predisposed to autoimmune cytopenias, whether it's immune thrombocytopenic purpura or autoimmune hemolytic anemia. Now, what would you expect in the labs? Clinically, mucocutaneous bleeding, lab-wise, thrombocytopenia with normal PT and BTT. So coagulation is not involved. Bleeding time, it would be prolonged because this is a platelet disorder. Okay? How I tell that this is ITP and it's not Bernard-Soulier or Glanzmann or von Willebrand disease, which are other diseases that involve platelets, the low platelet count. Okay? Because in Bernard-Soulier, in Glanzmann, and in von Willebrand, platelet count would be normal, while in ITP it will be low. Now, what other diseases cause low platelets? You have leukemias, and this could present with BTK, could present with bleeding. You also have thrombotic thrombocytopenic purpura and hemolytic uremic syndrome and disseminated intravascular coagulation. So how do you differentiate ITP from these? ITP is pure thrombocytopenia. There is no other involved cell line. While in TTP, HUS, DIC, and leukemia, you could have anemia ongoing. While again, ITP, it's a pure thrombocytopenia. Now, qualitative platelet disorders, we have Bernard-Soulier, where the problem is with adhesion, specifically the GB1P receptor. So platelet count would be normal, bleeding time will be prolonged, PT and PTT would be normal, and the huge clue for it is finding giant platelets on the blood smear. And that's very unique, it's pathognomic for Bernard-Soulier. You will never see it elsewhere. The complete opposite of giant platelets is small platelets, and that's called microthrombocytopenia. So low platelet count, and these platelets are small. We see that with Wiskott-Aldrich syndrome, which is an immunodeficiency disorder. And it has a triad of eczema, recurrent infections, and microthrombocytopenia. And since it's a low platelet count, they can present with bleeding, petechia, and so on. So this is another cause of a quantitative platelet disorder. Other qualitative, other than Bernard-Soulier, is Glanzmann thrombasthenia. And in these patients, the problem is with aggregation. So if we do a platelet aggregation test, it will be abnormal. Bleeding time will be prolonged, platelet count is normal, and PT and PTT are normal. The receptor here that is genetically abnormal is the GB2B3A, not the 1B, which is in Bernard-Soulier, that's involved in adhesion. Now, von Willebrand disease is an interesting one. It's the most common inherited coagulopathy, and it's mixed because it will involve both coagulation and platelet function. So this is the only disease that is mixed, involving both platelets and coagulation, both primary hemostasis and secondary hemostasis. So it could have manifestations from both. They could manifest with mucocutaneous plus deep bleeding, and it could be only mucocutaneous as well. How do I tell it from, for instance, ITP, immune thrombocytopenic purpura? In von Willebrand, you are going to have prolonged PTT because factor VIII will become depleted. Because in our blood, von Willebrand protein carries factor VIII. So once you have a defective or low count of von Willebrand factor VIII will become depleted. So And also, as we have mentioned initially in the physiology, von Willebrand protein is what binds to subendothelial collagen. So it's not binding, so platelets are not functioning well, and also you are having a deficiency of factor 8, which is a clotting factor. That's why it's mixed. That's why it could present with symptoms of both primary and secondary hemostasis disorders. Platelet count is usually normal. It could be low, but it's usually normal, and PTT is going to be prolonged. So if you see prolonged PTT with mucocutaneous bleeding, this is von Willebrand disease. You will never see it elsewhere. And again, it's the most common coagulopathy, so you need to have a low threshold of a clinical suspicion for it. So once you see a 15-year-old girl with heavy menstruation and her platelet count is normal, you have to think of von Willebrand disease. So these are the quantitative and the qualitative platelet disorders. A subsection of a quantitative platelet disorders that is a huge area of its own are microangiopathic hemolytic anemias. And from their name, microangiopathic hemolytic anemias do have anemia. So never mix them with immunothrombocytopenic purpura. Your patient will have hemolysis. They are going to have anemia, elevated LDH, low haptoglobin. All of these findings that line with hemolysis patients. And also they are going to have low platelets. So low platelets, low hemoglobin, and RBC count due to hemolysis. So reticulocyte count is going to be elevated. Because this is hemolysis, it's not a primary bone marrow issue. Unlike people with leukemia, who could present with BTK and so on, and fever, which is one of the features of these MAHA disorders that I will delve deep into in a second. However, someone with leukemia, the cause for the cytopenia, anemia, and the thrombocytopenia is bone marrow infiltration. So reticulocyte count is going to be low. There is no reactive response from the bone marrow to compensate. Unlike people with microangiopathic hemolytic anemia, where there is a reaction from the bone marrow, because the issue is peripheral. It's happening within the blood. It's not happening within the bone marrow. Okay, so I'm going to repeat that just to confirm that you got it. When you have multiple cytopenias, this could be thrombotic thrombocytopenic purpura, it could be hemolytic uremic syndrome, it could be DIC, it could be mechanical valve hemolysis, and it could be leukemia. All of the reasons other than leukemia, bone marrow is intact, so you will have increased reticulocyte count reacting to the hemolysis that's ongoing, to the loss of RBCs. While in bone marrow failure, which is due to leukemia, due to the infiltration, you are going to have a low reticulocyte count. Okay. Now, between the causes of MAHA, how do I tell if this is TTP, HUS, DIC, or mechanical valve hemolysis? Let's start with the easy one. Mechanical valve hemolysis is a 70-year-old patient who had aortic stenosis, and due to severe aortic stenosis or symptomatic heart failure due to the stenosis, had a valve replacement, and he is now presenting with pallor, anemia, low platelet count, and so on. What's the issue here? He is developing microangiopathic hemolytic anemia due to valve dysfunction, prosthetic valve dysfunction. Your best next step on the exam is to do an echocardiogram. It might not come to your mind, but you need to do that to see the valve, see the function of the valve, see if there is any thrombosis at the valve site, and so on. So the first step is echocardiogram. Now, for DIC, HUS, and TTP, first, DIC is combined coagulation and platelet issue. So there is the low platelets and the anemia, the MAHA, and there is also high BT and BTT, low fibrinogen because it's being consumed, and elevated D-dimer. So prolonged BT and BTT, low fibrinogen, elevated D-dimer with the MAHA, which is anemia and the thrombocytopenia. So as you can see, it's more extensive. While HUS and TTP, coagulation is normal. So prothrombin time, PTT, D-dimer, fibrinogen are going to be normal. Okay, now HUS and TTP, they have MAHA, so anemia, thrombocytopenia, low haptoglobin, high LDH, jaundice, all of the signs of hemolytic anemia, along with the thrombocytopenia that ongoes. So there will be petechia, they might have mucosal hemorrhage, all of these things. How do I differentiate them? HUS follows a bacterial gastroenteritis with a Shiga toxin producing bacteria like Shigella or most notoriously E. coli O157. So this is going to be in the past medical history of your patient. Moreover, TTP, which is the other disorder, thrombotic thrombocytopenic purpura, usually have neurologic symptoms like confusion that are not likely to be seen with HUS. HUS is primarily MAHA with renal failure, while TTB is MAHA with the neurologic symptoms and possible renal failure. So there is more neurologic symptoms with TTB, more renal symptoms with HUS, meaning nephritis. So you are going to have hematuria, the patient could be anuric, hypertensive, and so on. And creatinine and blood urea nitrogen will be elevated. So HUS is more renal, TTB is more neuro. However, this could be mixed. HUS have a previous history of bacterial gastroenteritis with a Shiga toxin-producing bacteria like E. coli O157, and this is usually happening in children, while TTB usually happens in women of middle age. So you could expect that. And the pathophysiology for it is autoantibodies against ADAM-TS13 protein. While for HUS, the pathophysiology is Shiga toxin-induced endothelial damage. All right. In all of MAHAs, TTB, HUS, DIC, and mechanical valve hemolysis, you are going to see schistocytes on your blood smear. So this is non-specific. However, if you say it, never pick immunothrombocytopenic purpura or all of the other diseases we mentioned, or leukemia, anything else, it's going to be between these four: TTB, HUS, DIC, and mechanical valve hemolysis. So we have already covered how you tell if it's HUS or TTB. DIC, again, the low platelets, the anemia, the MAHA, along with the elevated BT-BTT, low fibrinogen, elevated D-dimer. So you have this combined mess. And the reasons for DIC are also important. So someone could have been septic, they could have an ongoing malignancy. One high-yield topic is acute promyelocytic leukemia with translocation 15-17, where you will have rods on your blood smear within lymphoblasts, and that's a subtype of acute myeloid leukemia. So you're going to have these myeloblasts with rods and translocation 15-17 and a heightened risk of DIC. Now, moving on, just to touch on leukemias once again, only the acute promyelocytic leukemia can cause DIC, at least within exams, and the treatment for it is all trans-retinoic acid, so a vitamin A derivative. And generally, leukemias could cause thrombocytopenia resulting in bleedings that are mucocutaneous. And again, you see cytopenias, prolonged bleeding time, coagulation is normal. Now, vasculitis, and this is really an important topic, because vasculitis, usually they have normal platelets, they have normal BT and PTT, normal bleeding time, all of their platelet and coagulation workup is going to be normal. They will have multiple manifestations across multiple systems with their BTK or purpura. So don't mistake it with one of these platelet and coagulation disorders. Now we're going to test our knowledge with just a few cases. So let's say that a 5-week-old baby is brought to the hospital. He was born at home, and he was brought by his family because he started to have abnormal movements and his alertness was reduced. He was not looking at them, he was not feeding, and he had these abnormal movements where he was unresponsive to others. So this is a description of seizures. And now he comes to the hospital. He is also like lethargic, hypotonic. You have a tense anterior fontanelle. So what's going on here is probably an intracranial hemorrhage secondary to vitamin K deficiency. And vitamin K deficiency could present in individuals who are born at hospitals and refuse taking the vitamin K shot, or those born at home because of the lack of this postnatal care and the delivery of the vitamin K. So people susceptible to vitamin K deficiency are newborns, adults who are on total parenteral nutrition, adults who are receiving IV antibiotics for a prolonged period of time. Or even children, like anyone who's receiving IV antibiotics for a prolonged period of time, because this will deplete their microbiota. It will kill the normal flora in the gut that is making vitamin K for us. Lab-wise, you are going to see elevated BT and PTT, platelet count will be normal, bleeding time will be normal. So this is vitamin K related hemorrhage, and usually early in the neonatal period, it will cause bleedings like in the umbilical cord once it's cut, and so on and so forth, maybe within muscles, so muscle hematomas. And the later you go, the more there's a risk for intracranial hemorrhage. So any bleeding type could happen with vitamin K deficiency. Now let's say a 65-year-old man with aortic stenosis who had a valve replacement a few months ago, presents to you and he have a mechanical murmur, which is expected for someone who replaced his valve, and he has pallor and tiredness. What's your next best step? It's echocardiogram, because his anemia might be related to the hemolysis taking place at the valve, and obviously if they give you the total CBC, you could also see thrombocytopenia as well. And on the blood smear, you will see schistocytes, which is very important, which is the indicative, the most pathognomic and predicting sign of an ongoing microangiopathic hemolytic anemia. Okay, so let's say that a 7-year-old child presents to you with fever that has been ongoing for 3 days. He's also fatigued, he has loss of appetite, he has not been eating well, and has lost 2 kgs over the past 1 week. You note that there is a bruising on his legs and arms. He is brought with his mother. His father is not here, and the child isn't speaking much. So they will throw clues at you like this to make you think of child abuse, and it will be in the choices. Then they tell you that he has bone pain on palpation and pallor as well, and they will give you a CBC, and you will see low platelets, low RBCs, maybe elevated or low leukocyte count, and they will ask you what's the diagnosis. Even if they did hide the CBC, the bone pain, the bone tenderness, especially the long bones like the thigh, the femur, this is one of the signs of leukemia. And I have a cytopenia, nothing is mentioned about the blood smear having schistocytes or something like that, so this is going to be a leukemia in this patient. This is leukemia. So just a conclusion and a few takeaways. Mucocutaneous bleeding is typical of platelet disorders. So if you have a mucocutaneous bleeding with a low platelet count and purely a low platelet count, there is no other involved cell lines, that's immune thrombocytopenic purpura. If it was a mucocutaneous bleeding with a normal platelet count, that's a qualitative platelet disorder. This could be von Willebrand disease, where you will have elevated PTT, or it would be Glanzmann thrombasthenia, where you will have no additional findings and it's a problem with platelet aggregation, so maybe an abnormal platelet aggregation test if that was performed. And then you are going to have the last one, which is Bernard-Soulier, where you will have a macrothrombocytopenia, where you will have the thrombocytes being large in size. However, macrothrombocytes, but there is no penia, there is no deficiency. So normal platelet count with large platelets and the mucocutaneous bleeding. If you have schistocytes, this will indicate microangiopathic hemolytic anemia. DIC will have coagulation issues unlike the other MAHA causes. If you have pancytopenia and you see blasts on a smear and coagulation isn't involved, this is leukemia. The only one that could involve coagulation is acute promyelocytic leukemia causing DIC. Normal platelets, you have purpura, you have extra manifestations like arthritis, this could be vasculitis. Vitamin K deficiency, prolonged PT and BTT, in newborns, the malnourished individuals, people on IV antibiotics, total parenteral nutrition, and so on and so forth. What other causes we have that I'm going to finish with, because they are really very simple and straightforward, they are hemophilia A and B. Hemophilia A and B are going to be involving factor 8 and 9 respectively. Partial thromboplastin time will be elevated, prothrombin time will never be elevated, it's only BTT, and the management is to give the recombinant factors. Platelet count is normal, and so is the bleeding time. So these diseases are going to be a purely coagulation issue, purely secondary hemostasis. So their presentation is bleeding after teeth extraction, deep bleeding in joints and in muscles causing hematomas. And again, the management is the recombinant factor. Someone has a vitamin K deficiency, your management immediately is a prothrombin complex concentrate, and obviously you have to give vitamin K. However, prothrombin complex concentrate is your first step. If someone's disease is leukemia, that's a different story. You have to treat the leukemia. If someone has immune thrombocytopenic purpura, the management is observation, unless platelet count is less than 30,000 or the patient is bleeding, where you go for steroids. You also have the option of IVIG to escalate, and if these options fail, you have to go for splenectomy. Now for the management of HUS and TTP, for HUS, it's going to be primarily hydration. So you want to hydrate the patient and just give them a supportive management. You don't give them any anti-motility agents like erythromycin, metoclopramide. Any agents that slow down their gut are not given, because you want them to clear the bacteria and the toxin from their GI system. and so are antibiotics. So antibiotics and antidiarrheals are contraindicated. In TTB, your management is mainly plasmapheresis, so plasma exchange. You want to take that autoantibody against ADAM-TS13 from their system, and there is a rule also for a fresh frozen plasma to be given to these patients. But the primary thing is plasmapheresis. DIC, definitely it's fresh frozen plasma, cryoprecipitate. You want to give them clotting factors. So that's for the management of all of these conditions. I hope that this lecture was helpful. Definitely we can't go through everything about bleeding within 25 to 30 minutes. However, I hope that we covered an overview of these topics while also discussing some management and how you differentiate them. At the end of the day, that's the main message that I want to communicate from this podcast and these episodes, is how to differentiate these conditions. So if you had a problem with bleeding questions, I hope that you now have an approach. Always try to figure out, is this a platelet or coagulation issue? Be smart with the labs. Memorize well when they are abnormal and when they are not, and what different combinations you have, and you will be safe with bleeding questions. Thank you for watching, and see you in the next episode of the Differential podcast. Bye-bye.